consultant orthodontist and an assistant professor at Sree Balaji Dental College and Hospital. Today, I will be talking to you about the Frankel Appliance or the Functional Regulator Appliance. To just give you an idea, the Frankel Appliance is one of the most crucial functional appliances in functional jaw orthopedic treatment. Now, today's class, we're going to talk a little about the introduction of the appliance, a little into the history of where the appliance originated from, the various synonyms that you need to know as an undergrad, the philosophy behind the appliance, and the indications, contraindications, and clinical procedures involved in the fabrication of the Frankel appliance. Now, to begin with, like I already mentioned, the Frankel appliance is a removable functional appliance, and it is more so a tissue bone appliance, meaning which most of the appliance rests on the tissues intraorally. It can be given both in mixed and in early permanent dentitions, and it was developed by Professor Rolf Frankel in 1966. Now, it has two main treatment effects. Primarily, it serves as a template against which the craniofacial structures develop, and secondly, it influences this growth. It influences the growth of skeletal and dental tissues. Now, what I mean by this is something you will see when we come to the philosophy. Moving on, a brief history. You need to know where the appliance came from and what were the precursors of this appliance. Very early on in 1800s, in 1880, Kingsley came up with the concept of jumping the bite. Now, what does it mean? Basically, when you have a class 2 malocclusion, when the mandible is retrognathic, that is, the mandible is positioned behind your maxilla, to bring it forward, you need to open the bite a little. You need to relieve the occlusion to bring the mandible forward. This concept is called jumping the bite. Robin in 1902 gave the monoblock appliance, which was a single block of acrylic that did this purpose of jumping the bite. Now, in 1908, Viggo Anderson gave the activator, which was another monoblock appliance that did the same thing of jumping the bite. But unfortunately, the biggest challenge with these monoblock appliances was that they were bulky. There was a big chunk of plastic sitting intraorally, making it difficult for the patient to eat, chew, or speak, or do any of the functions. This was a major challenge that led to the evolution of smaller, simpler appliances that did the same thing as jumping the bite. The next important thing in history would be the oral screen, which was given by Krauss. Now, oral screen is a functional appliance, but it aids in eliminating the forces, muscular forces, rather than bringing the mandible forward. So why you need to know both of these concepts is that the Frankel appliance is a combination of eliminating muscular forces while simultaneously positioning your mandible in a forward position. Now, the synonyms of Frankel appliance. Frankel appliance has 4 main names, and each of these names has a history or a function behind it. First one, Frankel appliance, named after Rolf Frankel, who gave the appliance. Second one is a vestibular appliance. Vestibular appliance is an indication of where the appliance is going to sit. So the Frankel appliance sits in the labial and buccal vestibules, gaining the name vestibular appliance. The next is called the oral gymnastic appliance. Now, the Frankel appliance works by changing muscles, works by pulling muscles around, moving your teeth around, and therefore it causes a good change in position, good change in function of oral musculature, and giving it the name oral gymnastic appliance. And the last one is a functional regulator, which is very common, very simple to understand. Your Frankel appliance regulates the function of your mandibular musculature, giving it the name functional regulator. Now, Frankel, according to Rolf Frankel, he says that all the crowding and all the malocclusions that we see are a result of aberrant musculature. Now, when I say aberrant, it could mean either hypertonic or hypotonic, but any sort of deviation from the actual tonicity of a musculature is called aberrant musculature. So, any of these aberrant musculatures can cause changes in the intraoral component or the dental component, giving rise to different malocclusions. This was the concept with which Rolf Frankel developed the Frankel appliance. Moving on, now a little more into the philosophy of Frankel appliance. You need to know. So first, let's talk a little about the anatomy and musculature. So when I say musculature, in extraoral musculature, I'm talking about the buccinator mechanism, the orbicularis oris, the complex, the orbicularis oris complex, and the masseteric complex, masseteric sling. Now these, along with the tongue. Now these 4 muscles are quite powerful. They help us in moving our jaw around, give us facial expressions, mastication, all of these functions. But when these muscles are aberrant, which they don't function properly or they have a hyperfunction, they end up causing a restraining effect on the development of underlying structures. Now, let me take you back to the concept of functional matrix hypothesis. Functional matrix hypothesis, as you all know, simply says that form follows function, meaning which your shape, your morphology is defined by the function of a structure. The same concept applied here, wherein when you have aberrant musculatures, the form gets deformed. So basically, form follows function. As you can see on your screens right now, there's a little explanation or a flowchart of. Now, as you can see on your screens, there's a little flowchart explaining how Frankel appliance is going to work intraorally. But you need to remember all of these key concepts that I spoke about before. Form follows function, aberrant musculature. Now, your Frankel appliance has components called buccal shields and lip pads, which are small acrylic components that rest in the space between your teeth and your cheeks, which is the vestibular area. Now, when you have aberrant musculature, there's a pull on your teeth which is causing malocclusions. So what Frankel does is it sits in between this cheek musculature and your teeth, preventing those forces from the cheek musculature acting on your teeth. So basically, it eliminates the forces. It eliminates the aberrant forces that your musculature is putting on your teeth. So when your musculature, when the aberrant forces are eliminated, your jaws are free to grow. That is the whole idea of how a Frankel works. Now see, so there's tension. As soon as you put lip pads in, there is tension. Your cheeks and lips are pulled away from your teeth. There is tension, and this tension will cause some amount of bone resorption and bone remodeling happening on the periosteum of the mandible. Once the periosteum of the mandible starts to remodel, your mandible is directed in a forward direction. Your mandible is free to grow after your aberrant musculature has been removed. That is how a Frankel appliance works. It eliminates all of these aberrant forces. It doesn't directly reposition your mandible forward, but it eliminates all the aberrant forces, allowing your mandible to grow in its natural forward direction, forward and downward direction. This effect that we've been talking about all this while is called the buccal screening effect, or the screening effect of buccal shields of Frankel. I know it's a little long. It's basically the screening effect or the protective effect offered by these buccal pads and lip shields that are there in the Frankel appliance. Now, in which age groups do you give this? Again, going back to basics, you must remember that you can never grow your mandible in size. You can only redirect your mandibular growth. First point. Second point is that musculature, once established, is very hard to correct. So that's why we say we need to break habits at a very early age. So musculature, if your patterns have been set, are very hard to break. So the earlier you treat these aberrant musculatures, the better it is. So something between the ages of 8 to 10. So somewhere early on, prepubertal, between the ages of 10 where the musculature hasn't fully developed, are your primary criteria for giving the Frankel appliance. Additionally, in which malocclusions? We've been talking about functional correction. So basically, it's a class 2 malocclusion. But additionally, there are certain modifications of Frankel, which we will be talking about in the next class, which also allow you to deliver a Frankel appliance for a class 3 malocclusion or a class 3 mandible, which is a prognathic mandible. Following which, you can also give a Frankel appliance for patients with functional retrusion, with bimaxillary class 2s, with open bites, and various other minor malocclusions. Where will you not give Frankel? It's more important to know where not to give Frankel than to where to give Frankel. In a class 1 malocclusion with severe crowding, you do not give Frankel. Now, when there's already severe crowding, there's a space deficit, we don't know if there is any muscular aberration. Class 1s generally present with a very harmonious soft profile. So in these sort of malocclusions, you will not give a Frankel. Following which, if you have you have severe dentofacial deformities and permanent dentition, congenital abnormalities, missing teeth, lack of space, odontomes, any of these, you will not give a Frankel appliance. And most importantly, Frankel appliance depends 100% on patient compliance. Patient has to wear it for a certain period of time, patient has to keep it out, put it back in, and it purely depends on patient compliance. And we're talking about kids that are aged between 8 to 10. So compliance is of utmost priority when we talk about Frankel, and therefore uncooperative patients who are not willing for treatment, who are not willing to listen to you, please do not give them a Frankel. You will only burn your hands. Now moving on to the diagnosis. How do you decide if this patient requires Frankel or if Frankel is the correct treatment modality for this particular patient? There are three things additional to what we generally do in terms of case history taking, extraoral examination, intraoral examination. There are three other parameters that need to be done. First is called the visualized treatment objective, followed by cephalometrics and functional analysis. I wouldn't go into VTO in detail, but just to refresh you, VTO is where you ask a patient to protrude the mandible, a class 2 patient to bring the mandible forward to see if the profile improves or doesn't. If the profile improves, you know that the problem lies in the mandible and mandibular advancement is going to help you with treating this patient. But if the profile doesn't improve, it is called a negative VTO and it is something that cannot be treated with functional appliances. Then come your cephalometric evaluation. Your cephalometric evaluation, you will do the whole bunch of cephalometric analysis to establish if your mandible is retrognathic, retroposition, if your maxilla is orthognathic, how are the growth patterns, if it's a vertical growth pattern, horizontal growth pattern, how is the saddle angle. There are multiple parameters. There are a host of parameters to identify if the mandible is truly retropositioned for you to give a Frankel. And the next is your functional analysis. In your functional analysis, you will examine the musculature. You will see if the patient has a hypertonic lip or a hypertonic upper lip. Do they have an inverted lower lip? Do they have puckering of chin? Are they breathing through the nose or their mouth? How is the mastication? How is the speech? How is the TMJ? Your entire functional evaluation has to be done prior to deciding if the patient deserves a Frankel or otherwise. This completes the entire section of how to identify if a patient needs Frankel, and it is the introduction to Frankel. But now moving on to the clinical aspect of a Frankel appliance. So let's say, for example, you see an 11-year-old boy. He's got a hypertonic lower lip, he's got everted lower lip, he's got puckering of chin, he's got a class 2 retrognathic mandible with an orthognathic maxilla. He's ideal, we're good to start. Oh, and more importantly, he's also got mixed dentition. He's in the late mixed dentition with the ease present. Most ideal candidate for a Frankel appliance. And what do we do once we see this child? So the clinical steps. First step is separation. Now Frankel has both acrylic and wire components, and you must separate the teeth so that the wire components can comfortably sit in between without interfering with occlusion. Now when I say separation, usually it is you separate between the molars, between the maxillary canine and deciduous first molar. Again, when I say molars, I'm not talking about sixes, it is the deciduous, it is the E. E is expendable, right? So your wires are going to go sit between the deciduous second molars, deciduous first molars, and you do this 5 to 7 days prior to taking impressions for Frankel. Now, this procedure, other than separation, is also called disking. Now you can either put heavy elastic separators or you can do a little bit of disking, which is proximal reduction of the primary teeth. Remember, never touch the permanent teeth. It's only the deciduous molars that you are allowed to disc on. And if needed, if need be, you can also make a small occlusal rest, which is basically create a small triangular shaped fossa on the occlusal surface for where you want your metal components to rest. Now again, this is done a week prior to your impression taking because it needs so much time for the separation to happen. You put your separators or your heavy elastics a week prior and then you start taking impressions. The next step is the impression taking procedure. Impression taking, most often you take it with an alginate impression material or a hydrocolloid impression material. You should record the entire alveolar process, including the maxillary tuberosities, along with the mandibular buccal shells areas. Why do you need such a detailed impression? Now, Frankel is something that has components that go beyond your beyond your mucogingival fold. They go and sit in your vestibular area. So only when you record the alveolus in its entirety will you be able to fabricate buccal shields and acrylic components that fit perfectly well. If you do not record your alveolar process in its entirety, your adaptation of the acrylic components would be compromised, and therefore it is of importance that you record all your alveolar registrations properly prior to fabrication of your appliance. If need be, you're always allowed to rim your trays with wax, you're allowed to extend your trays with wax, but you need to cover the entire alveolar process with your impressions. And make sure, even though I say you need to cover your alveolar process, you must not extend, you must not violate the physiological limits. So make sure you have your physiological limits in mind and then take impressions. Do not overextend your impressions. So we've done separators, we've done impressions. Once our impressions are made, the next process is to get your models or your working models sorted. Once that is done, we move on to the next important step, which is the construction bite. As far as functional appliances are concerned, the construction bite is the most important step. It is that step that decides whether your appliance is going to be successful, whether your overall treatment is going to be successful or not. A construction bite is a bite that is taken in a forward position. That is, basically you want your mandible, you position your mandible in the position where you want it at the end of treatment and then record the relation. Now, when you record a relation in such a pattern, your appliance will allow the patient to hold the mandible in a forward position only. The appliance will not let the mandible come back. So when there is a forward tug on your mandible is forced to grow in that particular direction. That is the idea behind taking a construction bite in a forward position. The other important thing, or maybe a significant difference between Frankel and all the other functional appliances, is that the Frankel appliance can do a sagittal advancement of only 2 to 4 millimeters, a minimal sagittal advancement of 2 to 4 millimeters. Unlike your activator or your twin block where you can do up to 7 mm of sagittal advancement, your Frankel appliance allows only for 2 to 4 mm of sagittal advancement. Therefore, when you are taking your construction bite, make sure that your advancement lies within these limits and not beyond. And if it is beyond, you will have to go in for something called incremental advancements, wherein you do it during the course of treatment, you incrementally advance your mandible. But always remember, Frankel's initial construction bite, the advancement allowed is only between 2 to 4 mm. When you take a construction bite, it is prudent to make sure that your incisors are in an edge-to-edge relationship and they meet exactly there with your canines in a forward position and your molars in a forward position, giving rise to a class 1 sort of a buccal segment relationship. Obviously, any strain of facial muscles while taking this should be prevented. You will advance only till where your facial muscles are in harmony, beyond which you don't. Just like how you don't extend your impression borders, you don't extend your bite borders as well. And you hold the mandible in a desired position. Before you take the construction bite, you need to train the patient onto how to bite. Give them a mirror, make them sit upright, tell them that this is where your mandible or your lower jaw has to come, tell them that the midlines have to match, teach them what it is, guide their mandible, let them practice for 10 minutes and then put them on the chair with a wax bite. Do not do the wax bite at the first attempt. It is very challenging both for the operator and for the child, and you will lose the child's compliance if you put in a huge chunk of wax right away. So make sure the child is comfortable, make sure the child knows where to bite, train the child and then sit them up for your construction bite. And it's always important that your bite is registered with all the indentations of teeth and neatly done so that you don't mess up with your acrylic fabrication. And midline discrepancies are usually addressed. There are two concepts called laterognathy and lateroocclusion, which of course are beyond the scope of this lecture, but just to understand, not all midline discrepancies are treated by functional appliances. So you need to know which midline discrepancy is laterognathy, which is lateroocclusion, and plan your bite accordingly. The next step would be to trim our models. We have our working models, we have a construction bite. We need to trim our models so that we can design our acrylic components. Now the components that require trimming will be the buccal shields and the lip pads. And all of these components that are pushing your soft tissue away should be a minimum of 5 mm away from the alveolar process so that they allow for a wax framework that can be made, a wax relief framework that can be made. Now, lip pads. So lip pads, how do you trim? You carefully carve back almost 5 mm from the greatest curvature of your alveolar base. And this is where your wax relief is going to be placed, over which you will fabricate your lip pads. Lip pads are usually pear-shaped to match the contour of the alveolar bone. And the profile view, when you look at your model, should have a pear-shaped extension or semi-pear-shaped extension after trimming. Now, lower relief, we've spoken about the upper lip pads. Moving on to the lower relief. Lower relief should ideally be 12 mm below the gingival margin, and at least a 7 mm below the lower incisor gingival margin. Now these lower margins or lower reliefs are rhomboid acrylic lip pads. Their shape is slightly different and they are rhomboid in shape. Now you can see these images, the cross sections that I was talking to you about. A and C, if you carefully look at the images A and C, you can see that the shape does not match the pear-shaped cross section. You see that there's no sufficient clearance. Either in A you see that the height, the 5 mm margin that I was talking about, is not satisfied, and in C it is a more rectangular shape than a pear-shaped shape. Moving on to B and D, the model has been carved parallelly to adequate depth, giving rise to a pear-shaped lip pads. And when you see these pear-shaped lip pads, you will also see that they have a parallel pad orientation. What I mean by parallel pad orientation is that when you have such rounded parallel orientations, you avoid or you minimize the risk of damage to your soft tissues. When you don't carve your models properly, you don't place relief, your acrylic components are capable, or rather they will cause tissue damage and tissue injury. So it is very important that you carve your models carefully prior to fabrication of your Frankel appliance. The next acrylic component are the buccal shields. As the name suggests, the buccal shields are pieces of acrylic that sit in the buccal vestibular area. Lip pads are structures that hold the lip away from your teeth, so are there in the labial surface or the labial vestibule. Buccal shields keep your buccinator mechanism, keep your masseteric muscles away from, or keep your cheeks away from your teeth. So buccal shields seated in the buccal vestibule. Now, same way, similar, just like your lip pads, buccal shields are also, the areas for buccal shields are also trimmed and a wax relief is placed. The only thing is the sulcular depth is a little greater. Your lip pads went all the way only till 5 mm, but your buccal shields will extend a little, almost 10 to 12 mm into the sulcus. Now, the next are called seating grooves, which I already briefly mentioned when I spoke about separation. Seating grooves are those areas or those markings that you place. When they are done intraorally, you call them occlusal rest seats or disking. When you do that on the models, they're called seating grooves. These are spaces where the wires can flow and should be 1.5 mm wide, and deeper are better than shallow seating grooves. Why? The deeper your groove is, the wire, the 19 gauge wire, rests comfortably inside these grooves, allowing for or comfortably letting the patient occlude without disturbing the occlusion. So it's better to have 1.5 mm wide deep grooves instead of shallow grooves. Now the final trimming that you do, after all of this is done, after you've trimmed for lip pads, buccal shields, you've placed your seating grooves, you do your final trimming wherein you neaten up the wax bite, you neaten up the models, and everything needs to be flush, everything needs to be in one line. Now, working models, after you've done all the carving, have to be mounted onto an articulator so that you can fabricate your appliance. It's usually a 3-point articulator or even a fixator that you can mount these models onto. Once you mounted them, you will start placing your wax relief. You only carved, remember when I spoke about lip pads, buccal shields and seating grooves, we only spoke about carving. Once the areas have been carved, you need to fill them with wax or wax relief before you put on the acrylic on top. So this wax relief will prevent injury to your soft tissues. Now when I talk about lip pads, you have the labial frenum. When I talk about buccal shields, you have the buccal frenum. These are attachments, muscle attachments to the bone that need to be relieved. You cannot have a chunk of acrylic obstructing or hurting these frenum structures. Therefore, you need to place wax relief and modify it. We'll move on to the wire components of a Frankel appliance. Wire components of Frankel are few in number, but they should not be covered by acrylic. If they are covered by acrylic, you will not have movements. Your Frankel does not depend primarily on your wire components, unlike your removable appliances. Your wire components that are situated in the vestibule should be 1.5 mm to 2 mm away from the alveolar contour, and lingually also they need to be away from the mucosa and palate. You should not have wire components that are impinging on the soft tissues. They will cause a lot of injuries, and given that a Frankel appliance is something that is worn full time by the patient, when you have wire components, maintenance of oral hygiene also becomes difficult. Therefore, your wire components should have a minimum clearance of 1.5 to 2 mm from the soft tissues, be it the alveolar bone or be it the palate and the lingual mucosa. Now, I'll just give you a list of the different wire components that are used in Frankel. We will talk about all of these components in detail when we talk about the different types of Frankel. You have something called the lower lingual support wires, the lower labial wires, palatal bow, maxillary labial bow, canine loops, and the lower lingual loops. Now, lower lingual support wire. As the name suggests, it is in the lower arch, it is in the lingual area, and it offers support. So basically, it is made with an 0051 or a 0.051 inch stainless steel wire that runs lingual to the lingual aspect of your lower incisors. The next are the lower labial wires. The lower labial wires again are something like a labial bow. They are not called labial bow, they are just called lower labial wires, are wires that run on the labial aspect of your lower arch. These are made with 19 gauge stainless steel wire. The next is your palatal bow. Palatal bow is something similar to your TPA in structure. This palatal bow is made with 18 gauge SS wire. Next comes your maxillary labial bow. This is as simple as the labial bow that you would give for a Holly's appliance, but this is made with a 19 gauge. In a Holly's appliance, you would make your labial bow with a 21 gauge wire, but in a Frankel appliance, because you do not want any active movement, it is just to retain your appliance, you make it with a 19 gauge wire. Then you have something called the canine loops, which are also made with a 19 gauge wire, and the lower labial springs, which are made with a 22 or a 23 gauge stainless steel wires. Now, the last part of today's lecture is brief introduction into the different types of Frankel. There are 5 main broader classifications of the Frankel appliance or the functional regulator. The FR1, FR2, FR3, 4 and 5. FR1 has 3 subtypes. Now, in which cases will you use? The classification of FR primarily depends on the malocclusions that it is used for and the components that it contains. So each FR has a different set of components. Even though you have the same list of components, it's used in different permutations and combinations to get different results, and therefore you have these 5 types of functional regulators. The first type is usually used for class 1 and 2 division 1 malocclusions, meaning which FR1A, the subtype, that is used for class 1 malocclusions with minor crowding and class 1 with deep bite. Remember, the contraindication is class 1 with severe crowding, but the indication for FR1 is class 1 with minor crowding and a class 1 with deep bite. Moving on to FR1B. FR1B is for class 2 division 1 malocclusions with overjet less than 5 millimeters. And 1C is for class 2 division 2 malocclusions with overjet more than 7 mm. Now this is a little tricky, but with practice you will get used to it. FR1A is for class 1 malocclusions with minor crowding and with deep bite. FR1B is for class 2 division 1 malocclusions with overjet less than 5 mm, and class FR1C is for class 2 division 2 malocclusions with overjet greater than 7 mm. That completes FR1. FR2. FR2 is an appliance given for class 2 division 1 and division 2 malocclusions. Now you might ask me, what is the difference between FR2 and FR1B? Now FR1B is primarily for class 2 division 1 malocclusions with an overjet of less than 5 mm, and FR2 is for class 2 division 1 malocclusions with an overjet greater than 7 mm. Why is this difference? Again, go back to the white registration that I was talking about. Frankel, you can only advance or do a sagittal advancement of only 2 to 4 mm. So when you give an FR1B, your sagittal advancement is minimal. But when you have to go for an FR2, you have incremental sagittal advancements. That's the difference between 1B and 2. Even though they are both given for class 2 division 1 malocclusions, the extent of overjet determines whether you would do a single step advancement or a dual step or a sequential incremental advancement. Moving on to FR3, like I already mentioned, FR3 is for class 3 malocclusions. The positioning of your lip pads and buccal shields will vary, allowing for a maxillary pull so that your maxilla can come forward while the mandible has a restraining effect. That is a class 3 or that is a FR3 which is used for class 3 malocclusions. Moving on, the last 2 advancements or the last 2 modifications were quite recent if you look at the history of Frankel, FR4 and FR5. FR4 is given for open bite and bimaxillary protrusion cases, and FR5 is given for patients with vertical growth pattern or a high mandibular plane angle and maxillary excess. These are the basics of Frankel appliances and the different types. We will be looking at each of these appliances and its components and its uses in detail in the next lecture.